Welcome back to the new section on hyperkalemia. In this particular section, we'll be discussing on the etiology, clinical features, workup, and the management of hyperkalemia in detail. One important section within the hyperkalemia that is very, very important from the exam perspective is the management of hyperkalemia, which I'm going to discuss in great depth and detail. At the end, I'm also going to incorporate some case-based scenarios and ECG discussions which is pertinent to hyperkalemia, which is also important for your exams and your clinical practice. So let us start with the etiology of hyperkalemia first. We know that potassium homeostasis is regulated by three different areas. One is by the gastrointestinal tract and its absorption secretion of potassium. But even though it's a minor player, under certain circumstances, it's going to be a very important regulator. ICF, as always, is one of the very, very important regulators of blood potassium. And obviously the kidneys, which is going to regulate potassium in a great deal, especially with regards to the long-term control of potassium. Remember, ICF is going to control the potassium in the blood in the short run, whereas kidneys are the ones that are going to regulate the potassium in the blood in the longer run. So let us start with the GIT cause of hyperkalemia. Obviously, you know, increased oral intake alone cannot result in hyperkalemia unless and until there is another problem that is happening in the ICF uptake of potassium or kidneys excretion of potassium. We know that very well. So which means increased intake alone causing hyperkalemia is extremely less common unless and until there is a problem in the ICF uptake of potassium or the kidneys excretion of potassium. But there is one condition that you have to understand that can produce hyperkalemia, which is a GIT cause, is a very rare form called as ureterojejunectomy. This is a surgery where the ureters are transposed to the jejunum, where the urine will be actually coming through the gut. So the urine, when it reaches the jejunal mucosa, the jejunum tries to absorb the urinary potassium, resulting in hyperkalemia. So ureterojejunectomy can result in excessive potassium absorption from the jejunal mucosa, causing hyperkalemia. We can move off the GIT causes and move towards the ICF related causes. Obviously, your intracellular uptake of potassium is going to be really important for your potassium homeostasis. We discussed already, especially for short-term maintenance of potassium homeostasis in the blood. One of the major regulators of intracellular potassium uptake is the sodium-potassium ATPase. Sodium-potassium ATPase. There can be some conditions that can inhibit this sodium-potassium ATPase and related intracellular uptake of potassium, like for example insulin deficiency, which can very commonly happen in type 1 diabetes or late type 2 diabetes mellitus patients, because insulin is a very powerful stimulator of potassium uptake by stimulating the sodium-potassium ATPase through the insulin receptor IRS pathway. And second, if the patient is receiving drugs like beta blockers, especially non-selective beta blockers that have effect on both beta 1 and beta 2 receptors. Remember, beta 2 receptor stimulation by G stimulatory pathway, your sodium potassium ATPase is going to be activated, resulting in more potassium uptake. So beta 2 blockade may result in reduced potassium uptake by the cells, resulting in hyperkalemia. Remember, this effect is seen only with non-selective beta blockers and not seen with selective beta 1 blockers like atenolol or metoprolol. Number 3, digitalis overdose. Obviously, digoxin is a very important drug that can block the sodium potassium ATPase. By blocking the sodium potassium ATPase, you might result in hyperkalemic states. Similarly, there are some conditions that can increase the cellular exit of potassium and more potassium release into the blood, resulting in hyperkalemic states. So what are the conditions that are going to produce increased potassium exit from the cells, causing hyperkalemia? Condition number 1, obviously there are some drugs that can do this. For example, drugs that increases the muscle contraction, very importantly succinylcholine, because muscle contraction is always associated with potassium movement out of the muscle into the blood. So why this is important? Let me tell you. Remember, during muscle contraction, when you are exercising for that matters, there will be movement of potassium out of the muscle into the blood, especially locally within the muscle, to produce vasodilation because this potassium movement out of the muscle is important for producing vasodilation in that area. Vasodilation will increase the blood flow, thereby muscle is getting more blood during the exercise, which is a normal physiological phenomenon. But if the patient is having a hypokalemia and if they are doing an exercise, what will happen? If they are doing exercise during hypokalemic states, there will be lesser potassium in the blood, causing lesser vasodilation, which means if that patient is going for exercise, there's going to be a demand-supply mismatch, lesser blood flow, but the demand is more because muscle is getting exercise, which might result in lesser perfusion to the muscle, causing rhabdomyolysis. So 2 points here is very important. One is rhabdomyolysis can result in hyperkalemia, whereas hypokalemia itself can induce rhabdomyolysis. Very, very important points. Similarly, succinylcholine can produce rhabdomyolysis and hyperkalemia. Yes, possible because it produces more muscle contractions, and that is how it causes paralysis by causing continuous contractions and fatigue in the muscle. And we have another drug called epsilon aminocaproic acid, which can also produce hyperkalemia. And there are some drugs which activate the ATP sensitive potassium channels. What are the drugs that they cause hyperkalemia? First one is the diazoxide, second one calcineurin inhibitors, and third one is minoxidil. All these drugs can activate the ATP sensitive potassium channels, causing hyperkalemia. This is exactly opposite to what sulfonylureas do. Sulfonylureas actually block the ATP sensitive potassium channels. Once they block the ATP sensitive potassium channels, they are actually reducing the potassium efflux into the blood from the cells, resulting in more potassium within the cells, resulting in depolarization and insulin release. That's how they increase the insulin release. Whereas this diazoxide is a drug we know that is used in insulinomas. How they reduce the insulin release in insulinoma? By increasing the potassium release by ATP sensitive potassium channels, so that there will be lesser potassium within the cell, lesser depolarization and lesser insulin release. So exactly opposite mechanism to that of sulfonylureas, which we'll be discussing in detail in the diabetes chapter. Similarly, as I told you before, tissue catabolism of potassium rich cells, especially when they are broken down, they can result in hyperkalemia. For example, conditions like tumor lysis syndrome, where the hematopoietic cells will be destroyed, resulting in more potassium release into the blood, especially after chemotherapy. And we have rhabdomyolysis, which is going to result in release of potassium from the muscle because of muscle catabolism here. Number 3, if the patients are exercising, you might result in a transient hyperkalemia. Remember, exercise will not result in serious forms of hyperkalemia. It will result only in a transient hyperkalemia, just for 5 to 10 minutes. But remember, a hypokalemic patient doing an exercise will result in rhabdomyolysis per se. The concept behind which I discussed already. And there is a fourth mechanism called as solvent drag, which happens in hyperosmolar states. Which means when the patient is having a hyperosmolarity in the blood and the serum, there is going to be a movement of water from inside the cell to outside the cell, and this is going to bring potassium along with it by a mechanism called as solvent dragging, the details of which we have discussed already in the previous chapter on potassium homeostasis. Similarly, acidosis can retain the potassium within the blood and the serum, resulting in hyperkalemia. So acidosis does this by a variety of mechanisms, but even though indirectly the mechanism is by reducing the activity of sodium potassium ATPase. So in acidotic states, the cell tries to take up H plus that is increased, and in return they tend to give up potassium. That mechanism of which we have discussed in the previous chapter itself. So acidosis can result in hyperkalemia, but remember, only normal ion gap metabolic acidosis can result in hyperkalemia, not high ion gap metabolic acidosis. High ion gap metabolic acidosis as a sole reason for hyperkalemia is quite rare. And there is an entity called as pseudo hyperkalemia, which is also worth noting. So what do you mean by a pseudo hyperkalemia? It literally means a test tube hyperkalemia, which means in vivo there is no hyperkalemia, but the blood sample that is drawn will show hyperkalemia. So typically we call it as a test tube hyperkalemia or a pseudo hyperkalemia or a in vitro hyperkalemia. The conditions that can cause are blood drawing techniques, defects in blood drawing techniques, like for example, if the patient is clenching the fist for a long time. So that will result in increased potassium release from the muscles because you're clenching the fist for a long time. So the sample that is collected from that area will show a false hyperkalemic state. And second, it could be due to prolonged tourniquet application, especially if they apply tightly for a long time, that will result in ischemia to the muscles. Obviously, one of the important adaptive mechanisms to ischemia, as I told you before, is release of potassium. And if you collect blood from that area, obviously they might have a little bit of high potassium causing a pseudo hyperkalemic state. Or if the sample is stored for a longer time, so long specimen storage, obviously one by one the cells will wither and die, resulting in cell lysis and resultant hyperkalemia in the sample, and it's a pseudo hyperkalemic state. Or it can happen due to thrombocytosis and leukocytosis. In thrombocytosis, there is a dictum where every 1 lakh increase in the platelets will be usually associated with increase in the potassium by approximately 0.15. And this is a false effect, and this happens due to clotting. So once the sample clots, that will result in increased potassium movement from the platelets, increased potassium release from the platelets, thereby causing a pseudo hyperkalemic state. How can I identify this? It's quite simple. So we know the clotted sample is the problem here. So you test the serum potassium in the clotted sample, which means whenever I call a serum sample, means it's a clotted sample, and it will be little bit more compared to the unclotted sample, that is a plasma sample. So plasma sample is obtained by heparinizing it. So in heparinized sample, you check the potassium separately, and obviously you know in unclotted sample the potassium is going to reflect the true body's potassium, and the serum is going to have a more potassium relatively because of high platelets. And the difference between them, if it is more than 0.3, that confirms the existence of pseudo hyperkalemia. It's a very important thing to understand. So if they ask you what is the sample that you will prefer in patients with thrombocytosis for checking potassium, you have to always prefer a heparinized sample, not a serum potassium. Similarly, in leukocytosis, you might get a pseudo hyperkalemic state, typically in patients who are suffering from CLL, where the cells will be so fragile and they can break down very easily even after collecting the sample from the patient. So that's also the reason why you get this mud cells in the peripheral smear in patients with CLL. So that can cause more leakage of potassium because of increased cell destruction, because they are very fragile, causing a pseudo hyperkalemic state in the test tube. And interestingly, in patients who are suffering from CLL, the plasma potassium will be actually more than the serum potassium. This phenomenon is actually pseudo hyperkalemia, but it's also referred to as reverse pseudo hyperkalemia by certain textbooks. So that's why it's a very important terminology to know. So if they ask you what kind of sample that you will prefer in a patient who is suffering from CLL to avoid pseudo hyperkalemia, I'll be preferring a clotted sample, not a heparinized sample. That's a serum potassium is the preferred one here. Apart from that, you have a benign familial hyperkalemia, which is autosomal dominant in inheritance, which may or may not be associated with hereditary stomatocytosis. So, but the condition is benign familial hyperkalemia. So here, once the sample is taken from the patient, and supposedly if your room temperature is lesser than the body temperature, in lesser temperatures, the RBCs passively start leaking out the potassium, and that is the defect in these patients. And this is not associated with in vivo hyperkalemia, because the RBCs does not leak potassium in normal body temperature. Only if the sample is taken out, and unfortunately if your room temperature is lower than the body temperature, that is 37 degrees Celsius, then you might result in passive movement of potassium out of the RBCs, resulting in a pseudo hyperkalemic state. This condition may or may not be associated with stomatocytosis. How can you find out? So check the potassium immediately and store it at 37 degrees Celsius if possible, and check the potassium. And after that, serially reduce the temperature of the sample and check the potassium once again. So after reducing the temperature, if your potassium in the blood keeps on increasing, and at the body temperature, if your potassium is a little lesser compared to the room temperature, if the potassium is a little bit higher, in those conditions you can confirm the existence of this benign familial hyperkalemia with or without stomatocytosis. And we have to understand one other very important condition, which is actually very poorly understood even by research people, that is hyperkalemic periodic paralysis. Hyperkalemic periodic paralysis, which is a condition that is inherited as an autosomal dominant fashion. And the reason for this is mutation in the alpha 1 subunit of skeletal muscle sodium channel called as SCN4A, where it stands for skeletal muscle sodium channel number 4A. How this defective SCN4A channels is going to cause hyperkalemia and paralysis as well as stiffness in this patient is not clearly understood, even though we have some mechanisms for it, which I'm not going to discuss because it's not really important. But let us see the clinical features. The age of onset typically is around infantile period up to second decade. But overall, if you see the age group, they are relatively younger population. This is very important point because there is another condition that is associated with the periodic paralysis called hypokalemic periodic paralysis, which we'll be discussing subsequently in the next chapter, where you're going to have a little older population that will be affected. Here, younger people are going to be more affected. And clinical features, more importantly, they will be having episodic weakness. That's why it's called a periodic paralysis. And the weakness can last for approximately 10 to 60 minutes, even though the weakness can last up to 2 days in certain individuals according to the literature, but typical time frame for the weakness is going to be approximately 10 to 60 minutes, and the weakness is going to be relatively abrupt, which can actually result in falls in the patient as well. They can fall down because of the abrupt weakness, especially the proximal weakness, because it's a muscle disorder. And strikingly, they will not be having any bulbar or respiratory weakness. This point is again important because this helps in differentiating this disorder from another disorder, similar periodic paralysis disorder called hypokalemic periodic paralysis, where you will have a more incidence of respiratory and bulbar weakness. And there are some associated conditions along with this hyperkalemic periodic paralysis. One is Anderson syndrome, it is called as Anderson-Tawil syndrome. Remember the fact that Anderson syndrome can be associated with both hypo as well as hyperkalemic periodic paralysis, which means I'm going to mention this Anderson syndrome in the hypokalemic periodic paralysis also. And how will you differentiate this association? By the presence of long QT in the ECG, which means it's associated with sudden cardiac death. Naturally, any patient with long QT is associated with a sudden cardiac death risk. And it can be associated with another condition called paramyotonia congenita of von Eulenberg, which will be associated with myotonia, that is stiffness. So I can write paramyotonia congenita of von Eulenberg. So you can find out this association by the presence of myotonia in these individuals. Myotonia that is present in hyperkalemic periodic paralysis associated with paramyotonia congenita generally tends to increase with activity. So stiffness will increase with activity. That's a very important point. And at the same time, they can be seen whenever you lower the potassium aggressively during therapy. So whenever you see a high potassium patient is having paralysis, you tend to lower the potassium very aggressively. Just aggressive lowering of the potassium can increase the myotonia and stiffness. So how will you find out this disorder? Family history, episodic weakness, hyperkalemia in exams, along with stiffness of the muscle, that is myotonia. So these four things, if you see in the exam in a question, you can diagnose a hyperkalemic periodic paralysis. Investigation wise, you can do a serum potassium, but remember the fact that serum potassium is highly variable, especially during the attacks, where it can be increased, it can be normal, or it can be even reduced. So it's not reliable investigation. Ideally, you have to do a electromyography and genetic testing to confirm the disorder. But you have a lot of mutations, very difficult to find out, but genetic testing is on the way. Treatment, obviously you have to try to reduce the serum potassium because increased potassium is associated with weakness in this patient. So how will you reduce the potassium? By increasing the carbohydrate diet and by reducing the potassium in the diet. And you can use certain diuretic agents like loop diuretics or thiazide diuretics, which can reduce the amount of potassium in the body, and they can cause hypokalemia, not hyperkalemia. And beta-2 receptor agonists like albuterol, salbutamol, so which can result in low potassium in the body. that actually marks the end of this cellular causes causing hyperkalemia. We actually began with conditions that reduce the intracellular uptake of potassium. Then we moved on to the conditions that increase the cellular exit of potassium causing hyperkalemia. Then we saw a group of conditions causing a disorder called pseudo hyperkalemia or in vitro hyperkalemia. And finally, we completed the cellular cause of hyperkalemia with a very rare condition called hyperkalemic periodic paralysis. Now we are moving on to the kidney causes of hyperkalemia or renal cause of hyperkalemia. One of the most important and the most important is the low GFR, reduced filtration causing hyperkalemia, which is fairly common in the community, and one of the most common causes of hyperkalemia in the world is AK and CKD due to low GFR, reduced filtration of potassium, causing more potassium retention in the body, resulting in hyperkalemia. Apart from that, we know potassium is chiefly regulated at the distal nephron level through a very important channel that pushes potassium out and excretes, called as renal outer medullary potassium channels, called ROMK potassium channels. And this is usually coupled with the sodium reabsorption process through epithelial sodium channels, and these epithelial sodium channels are regulated by mineralocorticoid receptor. We know that, which in turn is regulated by aldosterone binding with the mineralocorticoid receptor. So renin, angiotensin, aldosterone, mineralocorticoid receptor and ENaC channels all play a very, very important role in regulation of potassium secretion into the urine. Clear? And at the same time, mineralocorticoid responsive organs like kidneys, colon and sweat glands are shielded from the effects of cortisol on mineralocorticoid receptor, because these organs contain a very important enzyme called 11-beta-HSD2, which is going to shield the organs from the effect of cortisol by converting cortisol to cortisone, which does not have any mineralocorticoid activity. Fine. Apart from this RAS system, mineralocorticoid receptor and ENaC channels, you have one more thing that determines the potassium excretion in the kidneys is the distal sodium and water delivery. We saw that already. Distal sodium and water delivery. Whenever there is reduced distal sodium and water delivery, you are going to end up in reduced sodium reabsorption, resulting in reduced potassium excretion as well, which in turn will result in more potassium retention and hyperkalemia. So conditions that cause are hypovolemic states, obviously, and in CHF and cirrhosis, you can result in hyperkalemia due to the same mechanism, because there is low effective arterial blood volume in these patients. And remember, CHF and cirrhosis can cause hyperkalemia due to various drug interactions itself, because in these patients you will be using a variety of drugs. For example, in a congestive cardiac failure, you will be using drugs like ACE inhibitors, drugs like spironolactone. That itself will interact and cause hyperkalemia. And this is also another mechanism of hyperkalemia in these patients. Apart from reduced distal sodium and water delivery, you can also get hyperkalemia due to problems in the renin-angiotensin-aldosterone axis and the ENaC receptors. So I can divide the conditions into conditions that produce aldosterone deficiency, and there are some conditions which produce aldosterone resistance. Aldosterone deficiency can be due to renin deficiency. Deficiency in renin is generally due to usage of drugs like NSAIDs, non-selective beta blockers, and that's rare, that's not common. At the same time, you can also have this renin deficiency due to diabetic kidney disease, the mechanisms of which we have discussed already in the previous videos. Apart from that, you can have increased renin and aldosterone deficiency, which is typically due to adrenal cause or something that reduces the aldosterone synthesis in the adrenal glands. Like, for example, giving a ACE inhibitor and angiotensin receptor blocker will have a high renin, but they will have reduced angiotensin 2, or angiotensin 2's action will be reduced in case of angiotensin receptor blockade, resulting in reduced activation of zona glomerulosa to produce aldosterone, resulting in aldosterone deficiency. Apart from that, you can have adrenal insufficiency, which itself can result in reduced aldosterone production and salt wasting. And apart from that, we know heparin can cause aldosterone deficiency in the long run, because heparin destroys the angiotensin 2 receptors, reducing the effectiveness of angiotensin 2 acting on the zona glomerulosa. At the same time, heparin can block the enzyme that is important for aldosterone synthesis, like 18-hydroxylase enzyme. It's one of the component of aldosterone synthase complex, so it can inhibit that particular component, resulting in reduced aldosterone production. So whatever it may be. So these are the 4 important causes, and that heparin will be the usual exam question. Aldosterone resistance can be due to many causes. So let us start with the resistance at the mineralocorticoid receptor level, which means mineralocorticoid receptors are not responding to the aldosterone that is present in the body. So problem in the mineralocorticoid receptor can be due to mineralocorticoid receptor antagonist or due to a type 1 pseudo hypoaldosteronism, which we have discussed in the previous chapter itself. So mineralocorticoid receptor antagonists like spironolactone and eplerenone, by blocking the mineralocorticoid receptors, can produce aldosterone resistance. Similarly, we have defects at the ENaC channels also, which means drugs like ENaC blockers like amiloride and triamtrin. These are potassium sparing diuretics, can result in aldosterone resistance. And remember, there are some drugs that mimic the ENaC blockers, that is amiloride and triamtrin, like pentamidine and trimethoprim. And these drugs mimic triamtrin and amiloride, and they can also act as a ENaC blocker, causing aldosterone resistance and hyperkalemia. So these are the 4 potassium sparing diuretics that you have to know for exams: spironolactone, eplerenone, amiloride and triamtrin. So there are, potassium sparing diuretics are divided into 2 broad classes. One is the mineralocorticoid receptor antagonists and the ENaC blockers. In general, we use mineralocorticoid receptor antagonists very commonly compared to ENaC blockers like amiloride, which is very commonly used in conditions like Liddle syndrome. That's it. Apart from that, you can have pseudohypoaldosteronism type 1, which can also result in a mutation in the ENaC channels, causing hyperkalemia due to aldosterone resistance, which we'll be discussing separately. So here I told only about the drugs. Then we have aldosterone resistance due to familial causes like pseudohypoaldosteronism. You have 2 types of pseudohypoaldosteronism. The nomenclature is quite confusing by different textbooks. Let me give you a new nomenclature. So type 1 pseudohypoaldosteronism is divided into 2 types. One is autosomal recessive type, which tends to be severe, and it's going to involve the ENaC channels. It's going to involve the ENaC channels. Clear? And if I tell the word severe, it's going to have systemic effects as well. That's why I tell the word severe. And second type is there, that is autosomal dominant in nature. It is less severe, and it's going to involve the mineralocorticoid receptors, and it's not that severe. And especially the severe form of type 1 pseudohypoaldosteronism, which is going to involve the ENaC channels, is going to have systemic effects on the colon, causing diarrhea, on the sweat glands, causing increased sweat chloride, and lungs, causing recurrent infections and bronchiectasis, so which can mimic a cystic fibrosis. Now, to differentiate from cystic fibrosis, we have discussed in the previous chapter itself. But please understand the fact that this type 2 pseudohypoaldosteronism is also referred to as Gordon syndrome by many textbooks. Especially nephrology textbooks give type 2 pseudohypoaldosteronism as Gordon syndrome, but endocrinology textbooks disagree with the fact. They call this type 2 pseudohypoaldosteronism as this mineralocorticoid receptor problem itself. But anyways, whatever may be the case, the understanding is the same, even though the nomenclatures are different. So let us see from the kidney and nephrology textbooks perspective, type 2 is called as Gordon syndrome, pseudohypoaldosteronism. So what do you mean by Gordon syndrome? So here the problem will be in the NCC transporter, which is present in the distal convoluted tubule. So what's going to happen here? This NCC transporter means it's a sodium chloride transporter or thiazide sensitive transporter, and you are going to have a gain of function mutation of this NCC transporter, which means they're going to cause more sodium and chloride reabsorption. So because of more sodium reabsorption, there will be increased volume in the body, and these patients are going to have hypertension. Clear? And because of increased sodium reabsorption at the DCT level itself, there will be reduced distal sodium delivery. Because of reduced sodium delivery to the distal nephron, in this area the sodium absorption will be less, and because of that the potassium excretion also will be less, resulting in hyperkalemia, and simultaneously it will be resulting in metabolic acidosis also, and this metabolic acidosis will be normal and NGAP metabolic acidosis, which is a very important point. And second mechanism that can cause hyperkalemia and metabolic acidosis is the fact that this hypertension and volume expansion may result in suppressed renin, angiotensin, aldosterone system activity, And because of reduced aldosterone itself, you will have reduced sodium reabsorption, resulting in reduced potassium excretion, causing hyperkalemia and metabolic acidosis. So that is the reason why this Gordon syndrome is also referred to as a familial hyperkalemic hypertension. Familial hyperkalemic hypertension. Very important name. It's the other name for Gordon syndrome. Hyperkalemic hypertension. Fine. So what is the reason, pathology behind this or genetics behind this development of Gordon syndrome? It is due to mutations in the WNK pathway with no lysine. K means lysine, with no lysine is what the expansion of this WNK gene. It could be a problem in the WNK1 or WNK4 gene, and the mutations of this will result in Gordon syndrome. So remember the fact that WNK1 gene mutation will be a gain of function mutation, whereas WNK4 gene mutation will be a loss of function mutation. There are some other mutations that has been described to cause Gordon syndrome, like you have KLHL3 mutations and you have CULIN3 mutations, also called as CUL3 mutations. These are rare mutations which can result in development of this Gordon syndrome as well. Apart from that, this WNK4 mutations are actually associated with another problem that is going to result in reduced calcium and osteoporosis, which means this WNK4 is also important for the regulation of a very important calcium channel called TRPV5 calcium channels, and there will be reduced activity of this TRPV5 calcium channels. These TRPV5 calcium channels are important for calcium reabsorption, the DCT, and that will be seriously hampered in patients who are having WNT4 mutations, resulting in hypercalciuria, which can actually progress to increased incidence of renal stones and nephrocalcinosis. And this hypercalciuria may be coupled with low calcium in the body, causing osteoporosis as well, osteomalacia and osteoporosis. So this is in particular is going to be associated with the WNT4 mutations and not the WNT1 mutations. Apart from that, we know there is going to be another condition called transient pseudohypoaldosteronism, and this is another condition that is going to cause aldosterone resistance, and this typically happens in patients who are having upper urinary tract infection like pyelonephritis, and patients who are having obstructive uropathy, which we have discussed already. Once these disorders are treated, the transient pseudohypoaldosteronism will resolve on itself and the aldosterone resistance will resolve on itself. And finally, there are some conditions which we don't know the clear-cut reason why they cause aldosterone resistance, like SLE, sickle cell disease, amyloidosis. We don't know the exact reason, but we think they cause tubular damage, especially in the distal nephron, causing aldosterone resistance, producing hyperkalemia and metabolic acidosis. Clear? So in a nutshell, we have four groups of renal cause of hyperkalemia. The first one is the low GFR, which is seen in AK and CKD, which is obviously the most common cause of hyperkalemia in the world. Then we have conditions that reduce the distal sodium and water delivery, causing hyperkalemia. We have discussed the causes already. And third group is the condition that produce aldosterone deficiency, causing hyperkalemia. And the fourth group is the conditions that produce aldosterone resistance, the tubular resistance to aldosterone, causing hyperkalemia. Let us move on to the clinical features of hyperkalemia. So remember the fact that clinical features and ECG changes will be dependent on the rapidity of development of hyperkalemia. For example, a potassium of 6.1 in a chronic kidney disease patient may not be associated with any clinical features or even ECG changes compared to the patient who's having an acute kidney injury, which has developed in the last couple of hours, can show all the clinical features and even arrhythmias in the ECG. So it all depends on how fast the electrolyte changes develops. That's what is going to determine the clinical features and the electrocardiographic findings. And the values of potassium and their correlation with your manifestations are little bit poor, especially at the lower ranges of potassium. But as the potassium increases further and further, like 7 and 8, the values of potassium is going to correlate a little well with the clinical features and the ECG changes. But let us discuss as a whole what's going to be the level of potassium and what will be the severity category and what will be the clinical manifestation, the ECG changes in this particular table. So first is the mild hyperkalemia, which is typically defined as potassium in the range of 5.5 to 6. Remember, 3.5 to 5 is the normal potassium, 5 to 5.5 5 is borderline hyperkalemia. Anything more than 5.5 is definite hyperkalemia. So 5.5 to 6 is mild hyperkalemia. Usually the patient will be asymptomatic. Once again, depends on the rapidity of development of this hyperkalemia. 6 in acute hyperkalemia, it can have clinical manifestations. Easy changes, usually non-specific changes may be there, but again depends on the rapidity of development of hyperkalemia. As the potassium keeps on increasing, they have a good correlation with the clinical features and ECG findings. So then we have moderate hyperkalemia, where the serum potassium tends to be in the range of 6 to 7 milliequivalents per liter, where the patient starts developing weakness, areflexia, and paresthesias. The mechanisms behind this is discussed in detail in the previous potassium homeostasis video itself. So if you have not watched it, please go back and watch and then come back to this video. And the classic ECG changes that are associated with moderate hyperkalemia include the classic tall T waves, which is supposed to be one of the earliest findings, but let me tell you, this is not a very sensitive as well as specific finding as far as hyperkalemia is concerned. You'll be quite surprised with my statement, but yes, it is true. But remember, the character of the T wave is more important in telling hyperkalemia or not, rather than just the presence of a tall T wave. So first, let us start with the basics. What do you mean by a tall T wave? Even though we are going to discuss all these things in detail in the cardiology ECG section, but let me tell you what do you mean by a tall T wave. Tall T wave means if it is more than 10 millimeter in chest leads. Chest leads means V1 to V6 classically. Or if it's more than 5 millimeter in amplitude and height in limb leads. So this is the definition of a tall T wave. Either if it's more than 10 millimeter in chest leads or if it's more than 5 millimeter in the limb leads. So what do you mean by this more than 10 millimeter? As a colloquial language, I can tell if it's more than 2 large boxes in amplitude in chest leads, which means one large box is 5 millimeter in width as well as 5 millimeter in height. So if it's more than 2 large box height, if the T wave is having more than 2 large boxes in amplitude, then you can tell a tall T wave if you are seeing in the chest leads. Or if it is more than 1 large box in limb leads. If the amplitude is more than 1 large box in limb leads, I can tell it's a tall T wave. Whether the tall T wave translates into hyperkalemia or not, let us see. For that, you have to know the normal looking T wave. Remember the fact the normal T wave is asymmetric regardless of the amplitude. So which means the upstroke is generally a little slow and the downstroke is generally rapid, right? So if you take the symmetricity of this, you can see very clearly it is asymmetric. And this is how a normal T wave is supposed to be. It is clearly asymmetric irrespective of the height of the T wave. Regardless of the height, a normal T wave must be asymmetric in nature. So let me draw another diagram which is going to show a tall T wave, but let us see whether it is related to hyperkalemia or not. So this is a QRS complex and you have a tall T wave here. So let us assume this meets the criteria of a tall T, alright. This meets the criteria of a tall T. Whether it is due to hyperkalemia or not, answer is no, because you can see a same slow upstroke with a rapid downstroke, and if you see the symmetricity in this T wave, it is very, very clear that it is asymmetric. So which means this patient is having a tall T wave in the EKG, but whether it is due to hyperkalemia or not, my answer will be a concrete no, because it's an asymmetric T wave which is actually normal. Then let me draw another tall T wave which resembles something like this. So here if I take the symmetricity, I can very clearly see that the patient is having a extremely symmetric T wave, which means this meets the criteria for a tall T wave, alright. And yes, this patient is suffering from hyperkalemia as well because of the symmetricity of the T wave. That's what is more important than the tallness of the T wave, as I told you before. And at the same time, let me draw another EKG where you might not have the T wave that is up to the criteria for the tall T wave, which means you have a little bit of tall T wave, but you don't have the T wave that is marking the tall T wave criteria or that is satisfying the tall T wave criteria, which means here the patient is not having that much tall T wave to call it as a tall T wave, but still it is extremely symmetric. And I can draw the symmetricity diagram here, so which tells you clearly it is symmetric in nature. even though I don't have a criteria that is fulfilling the tall T wave, still I'll be taking this patient as suffering from hyperkalemia, which means the symmetricity of the T wave is more important than the tallness of the T wave as far as hyperkalemic T waves are concerned. Clear, this is also referred to as a tall tented T waves because they are symmetric in nature. And hyperkalemia can be generalized as far as ECG is concerned. Generalized hyperkalemia can cause tall T waves, or a localized hyperkalemia can also produce a tall T waves, like in acute myocardial infarction. In acute myocardial infarction, there are a lot of reasons why you get localized hyperkalemia. The one reason is ischemia causing low ATP production, resulting in low sodium potassium ATPase activity, resulting in more potassium retention outside the cell. That's a localized hyperkalemia causing a tall T wave in hyperacute stages of myocardial infarction as well, which we'll be discussing in detail in the cardiology chapter. So fine. So now we have understood about the tall T waves and the character of the T waves, which is even more important than the tall T wave finding. Even the tall T waves are really common, one of the early findings in hyperkalemia, but see, the exact nature of the T wave is more important than the height of the T wave. Next, we have severe hyperkalemia, where the potassium tends to be somewhere in the range of 78, and very severe hyperkalemia is defined as potassium more than 8. And whenever the potassium crosses 7, there is a good correlation with the clinical findings and EKG findings as well. Less than 7, you may or may not have a good correlation because that depends on the rapidity of change in the potassium, but severe and very severe, more than 7 has a good correlation with clinical features and ECG findings. So more than 7 means generally you tend to go for complete paralysis, respiratory failure, and cardiac arrest by asystole as well. As I told you before, in hyperkalemia, the heart stops in diastole, and hypocalcemia, the heart stops in systole. EKG changes that are associated with severe hyperkalemia can be termed by the word bizarre, which means you can see a different or any kind of EKG changes. And that's why I also refer this hyperkalemia to the syphilis of the electrocardiogram. So like syphilis affects each and every organ in the body, hyperkalemia can cause anything and everything in the ECG. Like it can cause blogs, or it can cause arrhythmias, increase excitation. So the changes are complex, and the mechanisms behind these changes we have discussed in a relatively detailed fashion in the previous potassium homeostasis video itself. Blogs means the worst affected tissue as far as hyperkalemia is concerned is atrium. Atrium is one of the very sensitive tissues for hyperkalemia. So what can peculiarly happen in the atrium is the fact that these patients may have atrial paralysis, which means because of hyperkalemia, the conduction in the atrium can be completely blocked, which means there will be no atrial depolarization, resulting in absent P wave. There will be no P wave. Initially P wave will widen all right, but later on P wave will not be there at all. But there could be experimentally one thing that is possible, that the SA node can still be active in these patients, which may still be throwing impulses towards the AV node, but atrium will not depolarize, but this impulse can sometimes be conducted through the AV node and through the His bundle system to the ventricles. What really happens here is you will not get a P wave and you will get a ventricular conduction, which means you will result in a QRS complex. So this might look like as if the patient is having a junctional rhythm. This might look like as if the patient is having a junctional rhythm because you don't have a P wave and you have a narrow complex QRS, means in cardiology we take it as a junctional rhythm unless proved otherwise. But this could be a sinoventricular rhythm as well as hyperkalemia is concerned. What do you mean by sinoventricular rhythm? Impulse from the synode directly jumping to the AV node without atrial depolarization and no P wave. So you don't have a P wave, suddenly a QRS complex and a T wave will be there. So this is what we refer to as a sinoventricular conduction, which is a closed DD for junctional rhythm, and it's literally impossible to differentiate sinoventricular rhythm from junctional rhythm as far as hyperkalemia is concerned. So let us go back to the EKG changes. In the atrium, because the atrium is one of the worst affected tissues in hyperkalemia and is very sensitive to hyperkalemic changes, initially will result in a wide P wave, then you will result in an absent P wave. Absent P wave. Once the P wave is absent, this is termed by a phenomenon called atrial standstill, and that is where you might have a rhythm that is similar to junctional rhythm, but it may be due to sinoventricular conduction, which happens typically in hyperkalemic patients. And second, you can have SI nodal issues like sinus bradycardia, sinus arrest, completely because of complete loss of conduction within the sinus node, and you can result in AV blocks of any kind like first degree, second degree, third degree. Anything can be seen in hyperkalemia because of slowed conduction in the AV node, and you can result in bundle branch block, fascicular blocks, left anterior, left posterior, any fascicular blocks can be seen. And number 5, you can result in prolonged QRS that may be because of bundle branch block itself, and typically slowed conduction through the bundle of S and the Purkinje system. So widened QRS. And significant widening of the QRS. Initially, if you take this is the normal QRS, in hyperkalemia you'll have a wide QRS like this. Over time, this wide QRS may widen even more, and you have a T wave. So QRS and a T wave, and a QRS and a T wave like this, which can form a particular type of pattern called a sine wave pattern. And that is due to significant widening of the QRS that results in the sine wave pattern. And finally, complete blockade everywhere, resulting in a asystole and a diastolic cardiac arrest. Clear? At the same time, hyperkalemia can produce a variety of arrhythmias, including ventricular tachycardia and ventricular fibrillation as well. But please understand the fact, I told you QRS will widen in patients with hyperkalemia, and ventricular tachycardia is also a tachycardia due to wide QRS tachycardia. That's a broad complex tachycardia. And whenever you see QRS with either in a patient with a hyperkalemia and a VT, or in a patient who is not having a VT but having a wide QRS, if the QRS is more than 0.24 seconds, that is almost diagnostic of hyperkalemia, because there is no other condition in the world that can cause widened QRS to more than 0.24 seconds. For that matter, normal QRS width is less than 0.12 seconds or 120 milliseconds. If the QRS width is more than 240 milliseconds, it is hyperkalemia unless proved otherwise. Even if you see a ventricular tachycardia with a QRS width more than 120 milliseconds, you diagnose hyperkalemia related ventricular tachycardia and not anything else. So this is a very, very important point. Once again. Fine. So that's why I told you hyperkalemia means bizarre. It can produce conduction blocks as well as increased excitation causing arrhythmias. Both can happen synchronously. And remember the fact that potassium levels of more than 7 predisposes to development of arrhythmias as well as development of conduction blocks and diastolic cardiac arrest. So anything more than 7 is highly, highly dangerous. So that's why we keep a cutoff of severe hyperkalemia that is that you have to treat definitely as 6.5. Anything more than 6.5 is very, very dangerous, especially more than 7, definite and 100% risk of cardiac arrhythmias and asystolic cardiac arrest. So with this, we have completed the clinical features of hyperkalemia, and we'll be moving on to the treatment of hyperkalemia, which is more important than the workup itself. Because hyperkalemia is dangerous, at the same time, it needs a multimodal approach and treatment. Especially if the patient is having EKG changes, you have to treat in a little different way compared to patients who don't have EKG changes. You will be treating in a certainly a different way. So let us go on to the actual treatment of hyperkalemia, where I have given a table here, which is very, very important for your exams to understand. So I have divided into mechanism, drugs, dose, onset, duration, and finally comments, which is even more important. So let us start with the first drug, which is going to act by stabilizing the cardiac membrane potential. Stabilizing the cardiac membrane potential, and that is nothing but IV calcium. IV calcium is given in two forms. One is the calcium gluconate form, and second is the calcium chloride form. So both of which we'll be discussing in some time. But first of all, how does this IV calcium works? How does it going to stabilize the cardiac membrane potential? For this, you have to understand the genesis of EKG changes and arrhythmias and conduction blocks in patients with hyperkalemia. I told you the fact that there is a resting membrane potential and this is the threshold potential. The problem in hyperkalemia is the fact that you are going to have a new resting membrane potential at this location, which means it will be less negative, or it will be much closer to the threshold potential, which typically shows you the fact that it's closer to the threshold potential means there will be increased excitability, and that is the reason why you result in ventricular arrhythmias in patients with hyperkalemia, because it's closer to the threshold potential. At the same time, I told you the gap between the threshold potential and RMP is very, very important, which determines the number of sodium channels that open. So if the gap is very less, there will be reduced number of sodium channels that are opening. That results in reduced strength of contraction and strength of firing. Magnitude of action potential will be less, resulting in conduction blocks. Refractoriness will increase, resulting in conduction blocks. The main reason for all these problems, arrhythmias as well as conduction blocks, is the fact that RMP becomes less negative. Clear? And it comes closer to threshold potential, that's all. So giving IV calcium, how it's going to help? So calcium is a membrane stabilizer. How it does that? So it's going to raise the threshold potential to a new value, which means after giving calcium, your threshold potential will be at this level, which means this will be the new threshold potential after giving IV calcium. Which means please understand the fact calcium does not affect the resting membrane potential. Potassium will. But calcium is going to affect only the threshold potential and again not the resting membrane potential. So giving calcium will raise the threshold potential. Hyperkalemia, raise threshold potential. Hypocalcemia, reduce threshold potential. That is also the reason why patients who are having hypercalcemia will have a raised threshold potential, which means it's difficult to reach the threshold potential, resulting in neuromuscular weakness and even constipation. Reduced serum calcium is associated with neuromuscular irritability because that will reduce the threshold potential, comes closer to the resting membrane potential, causing more contractions, resulting in tetany. Remember, intracellular calcium is different from extracellular calcium. Intracellular calcium declines, lesser contraction, increases, more contraction. Extracellular calcium is different. Serum calcium increases weakness, reduced means neuromuscular irritability will increase, resulting in tetany. So the same principle we are going to utilize here. So serum calcium increase threshold potential, which means you have some time. So now, even if it's the RMP is increased, it takes a long time to reach the threshold potential, right? Now it takes a long time to reach the threshold potential, and the gap between the RMP and threshold potential is now a little bit wide, resulting in good contraction and more number of sodium channels will open, and at the same time arrhythmogenic potential will be less, alleviating both conduction blocks as well as arrhythmias in this case. And what is the dose of calcium you are going to give? So it depends on whether you are going to use a calcium gluconate or a calcium chloride. Suppose if you are going to use a calcium gluconate, you will be using 3 ampules of calcium gluconate, of 10% calcium gluconate. Each ampule will contain 10 ml, so 3 ampules will come up to 30 ml calcium gluconate, which is going to contain 14 milliequivalents of calcium. That's the dose we prefer. Remember, calcium gluconate should be given in peripheral line. Can be given in central line, I'm not telling no, but it can be given in peripheral line as well. Calcium chloride, on the other hand, is containing more concentration of calcium compared to gluconate solution, so where you need just 1 ampule of calcium chloride, 10% calcium chloride, which means only 10 ml you are going to give, which itself is going to contain 13.6 milliequivalents of calcium. And remember the fact that calcium chloride has to be given in the central line only, not peripheral line. It's better to give in the central line. So calcium gluconate, 3 ampules, 30 ml, 10% calcium gluconate contains 14 milliequivalents given in the peripheral line. Calcium chloride, 1 ampule, 10%, 10 ml contains 13.6 milliequivalents of calcium given in the central line usually. Onset of action starts within 1 to 3 minutes. Within 3 minutes, the action will start, and the duration of action lasts for 30 to 60 minutes, which means it's only a temporizing measure. Before the action of calcium gluconate wanes off, you have to give definitive potassium lowering therapy. Like, you have to decide on that, which we'll be discussing subsequently. Comments, it is highly irritable substance and it can cause phlebitis by its own. And remember, one of the other important compounds that is often used in hyperkalemic patients is soda bicarbonate. So avoid giving calcium in soda bicarbonate line. So there will be a Venflon or a IV cannula that is where you are infusing soda bicarbonate, and you put a separate cannula and you infuse the calcium gluconate through that line. Because there is interaction between calcium gluconate and soda bicarbonate, and both can interact and they can precipitate in the cannula itself or in the blood, which is going to result in even more problems, and don't do that. So you have to give in a separate line. Avoid giving in soda bicarbonate line. If it's not soda bicarbonate, then you can give in the usual line itself, not a problem. Then third, one of the very important and controversial thing is whether to avoid this in digitalis toxicity or not, because digitalis toxicity itself can cause hyperkalemia, whether you will give calcium gluconate in that setting or not. Many anecdotal reports tell that giving calcium in a patient with digitalis toxicity will result in a stone heart syndrome. Like, for example, Already the heart is loaded with calcium in patients with digitalis, and giving more calcium gluconate may result in more calcium ingress due to digitalis related problem and results in contraction of the death during systole. So that is result in that is called as a stone heart syndrome. The heart will be like a stone because it stops in systole. But this has been disproved by a lot of modern trials where you can give calcium and it is not related to intracellular calcium at all, what you are giving extracellularly. So this is quite controversial. But even now, we follow the practice that we have to avoid calcium in digitalis toxicity, even if the patient is having hyperkalemia, because hyperkalemia is one of the very important side effects of digitalis toxicity, which I have told you already. So it's better to avoid calcium in digitalis toxicity related hyperkalemia as of now. But even though trials are ongoing and many trials are proving otherwise, you can give calcium, no problem, according to the modern trials. But it's quite controversial. Number 2, there are some drugs which act by producing intracellular shift of potassium. Intracellular shift of potassium. So thereby causing reduced potassium in the blood, resulting in normokalemic state. So what are the drugs that do that? So first is insulin with dextrose. We know insulin is going to increase the activity of sodium potassium ATPase, and thus it is going to increase the movement of potassium into the cell. That's how it's going to work. And why dextrose? To prevent the potential hypoglycemia that is going to result as a result of giving insulin. So what is the dose you're going to use? I'm going to use 10 units of regular insulin. Remember, very commonly only regular insulin we use as IV. Analog insulins, yes, certain rapid acting analog insulins are approved to give in IV, but it's better to always give a regular insulin which is time tested and much safer in this setting. Regular insulin, at the same time you can add with 25 grams of glucose. You can give 25 grams of glucose, but giving glucose is indicated only if the CBG is less than 250. If the capillary blood glucose is already more than 250, then you need not give this glucose dextrose solution. Dextrose solutions can be avoided. And this glucose infusions can be achieved by giving 50 ml of 50% dextrose, which is going to contain 25 grams of glucose. 50 ml of 50% dextrose, D50. That's what we're going to give. So onset of action within 15 to 30 minutes, it's going to start acting. And the action lasts for 4 to 6 hours. Once again, it's a temporizing measure. You cannot rely on this for a long time. Once again, the potassium that has moved inside with the effect of insulin is going to come out of the cell and cause hyperkalemia again once the insulin effect is gone. So you have to go for a definitive measure before that. And what are the comments? Patients are having risk of hypoglycemia, especially if CBG is less than 250. That's why we are adding dextrose if capillary blood glucose is less than 250. This is very true, especially in late stage CKD like CKD stages 4 and 5. Advanced CKD, those who are on dialysis, this is more dangerous. Giving insulin, they are at more risk of hypoglycemia because of multiple reasons. Because CKD patients may have increased half-life of insulin because kidney clears insulin to an extent. And at the same time, how much potassium you can decrease with this method is approximately 0.5 to 1.2 milliequivalents per liter. So this much potassium you can decrease. Often, IV calcium is given along with insulin plus dextrose. Both are given simultaneously most of the times. And second treatment that can produce intracellular shift is the beta-2 receptor agonist. Beta-2 receptor agonist, and typically the drug that we are going to use is albuterol. That is nothing but salbutamol. Albuterol, nothing but salbutamol. So we are going to give albuterol in a nebulized fashion, typically in 10 to 20 milligram nebulized doses, which can produce intracellular shift by activating the sodium potassium ATPase. And onset within 15 to 30 minutes, like insulin and dextrose, and effect lasts for 4 to 6 hours, a transient effect. Before that, you have to go for definitive potassium lowering therapy, and potassium decline that you're going to achieve with this measure is approximately 0.5 to 1.5 milliequivalents per liter. Often, this albuterol nebulizations are used as adjuvants for insulin and dextrose therapy. So, calcium gluconate will generally be given along with insulin dextrose plus or minus albuterol nebulizations or salbutamol nebulizations, which acts as an adjunctive therapy along with insulin and dextrose. Then soda bicarbonate, which was very commonly used in the past, but currently we don't use it that often unless and until there are certain definitive indications are there, which I will tell you. So typical dose of soda bicarbonate is 1 milliequivalent per kilogram. 1 milliequivalent per kilogram dose. Approximately we are going to give 150 milliequivalent. This is the standard dose in 1 liter of 5% dextrose. Clear? 1 liter of 5% dextrose and 150 milliequivalents of soda bicarbonate is what we are going to give. And it starts acting within 15 to 30 minutes like other measures which I've told you. And duration of action is variable, and often you have a prolonged action like 10-15 hours compared to other modalities. But still it is unreliable, and it will be effective only in patients with acidosis. You have to be very clear. The soda bicarbonate therapy works only if the patient is acidotic, which means pH should be less than 7.2, or the patient should be at least a CKD patient. CKD patients, naturally they will have acidosis. So if the patient is acidotic, it works, otherwise it won't work. If the patient is having a normal pH, do not try soda bicarbonate. It is not going to work, clearly. And one more important point is, do not give soda bicarbonate in calcium line and vice versa. So if you're using a calcium line, giving calcium in one line, so do not use the same line for soda bicarbonate. As I've told you before, use a separate line for soda bicarbonate because they precipitate and you're going to result in more problems. And after these 3 therapies, we have a definitive potassium lowering therapy. These are definitive potassium lowering therapies in the sense they are going to reduce the total body potassium. Total body potassium, which means your calcium is not going to reduce the total body potassium. In fact, this IV calcium has no effect on serum calcium. That's a very important point. So they are not going to affect the serum potassium at all. Just they are going to stabilize the membrane. So intracellular shift, they produce lowering of the serum potassium, but it's only transient, and there will be risk of rebound hyperkalemia in this with these drugs. And at the same time, they do not reduce total body potassium, which means there is no change in the total body potassium. They transiently cause intracellular shift, which is going to come back again. So the whole body potassium is same only. There is no change. But there are some definitive therapies that can lower the serum potassium. At the same time, they lower the total body potassium also, which is very important. And that's why it's a definitive potassium lowering therapy. So what are the modalities that are available? One is the elimination of potassium through the GIT route. So elimination of the potassium through the GIT route is achieved through various cation exchanges, resins and polymers, which include drugs like sodium polystyrene sulfonate, which I'm going to discuss in detail, SPS, otherwise referred to as kyaxylate, and second one we have drugs like patriomer, which is commonly used nowadays, and third we have drugs like sodium zirconium cryosilicate, otherwise called as ZS9. This is a new drug which is not yet available in the market, but still it is emerging as a very, very good drug. And sodium polystyrene sulfonate dose typically is approximately 15 to 60 gram oral dose per day, 15 to 60 gram per day. It can be given as enema also. Approximately 50 gram is the dose for enema, but 15 to 60 gram per day is the oral dose. Patriomer typically 8.4 to 25.2 grams per day. That's the standard dose of patriomer. And sodium zirconium cryosilicate will give it a dose of 10 grams per day. Typically 5 to 10 grams per day. We prefer 10 grams per day. And the onset of action is variable. Duration is also variable. And let me tell you the comparison in some time. I'm not going to tell any comments. I'm going to compare and contrast each and every drug in some time. So then I can eliminate through the kidney route also. Renal elimination can be enhanced using loop diuretics. So where I will be using furosemide, and the dose is variable, and the dose will be dependent on the renal function. If the renal function is good, you might be needing a little lesser dose. If the renal function is very poor, you might be needing a very high dose. So dose depends on renal function. In general, you can go up to 160 to 200 milligrams of furosemide in very poor renal function. So onset of action within 30 minutes, and the duration of action is highly variable. And you can use this in patients who are having both acute as well as chronic hyperkalemia. Both acute as well as chronic hyperkalemia, you can use this furosemide, loop diuretics. And finally, you have extracorporeal elimination through dialysis. Dialysis is the technique here. Dialysis, there is no dose as far as dialysis is concerned, and onset of action is immediate. That's very, very important. One of the best treatment modalities for hyperkalemia and refractory hyperkalemia is dialysis. Dialysis can reduce the potassium to a great extent, and it can make the potassium completely normal within a few hours. So that's why it's immediate almost. Once again, the duration of effect of dialysis is variable, but even though it reduces the total body potassium. And what are the comments? HD is better than PD in removing potassium, which means hemodialysis is better than peritoneal dialysis in removing potassium. Suppose in case of ongoing release, in case of ongoing potassium release, so can you tell me two conditions which I have already mentioned where you can have ongoing potassium release? One is tumor lysis syndrome and rhabdomyolysis. In these two settings, it's better to add CRRT, that is continuous renal replacement therapy post hemodialysis. So even if you have done a hemodialysis, after doing hemodialysis in patients who are having ongoing potassium release, you can continue after the dialysis with CRRT, continuous replacement therapy, because once again, because there is ongoing potassium release, if whatever dialysis has removed, this ongoing potassium release from the tissues will result in rebound hyperkalemia. So to avoid that, you add a CRRT in this setting. And there are some rules and regulations for dialysate potassium also. Remember, dialysate potassium should be maintained at a value of more than 2. This is very, very important because there are multiple trials which have showed if you have used a dialysate potassium of less than 2, it is associated with faster reduction in potassium and sudden cardiac arrest. So dialysate potassium less than 2 associated with sudden cardiac arrest because of very fast reduction in the serum potassium. So more than 2 is the ideal number, 2 or more. So rebound increase in potassium after hemodialysis is actually common. So why it is common? I mean, in which places it is common, especially if you have used pre-HD intracellular shift therapies. So if you have used some therapies before the dialysis that have pushed the potassium into the intracellular fluid, so after the dialysis that potassium is going to come out, and post-dialysis hyperkalemia is quite common. So that is the reason why post-dialysis hypokalemia is never treated. So that is the reason why post-dialysis hypokalemia is never treated unless and until it's very severe. Because obviously after dialysis, if you have a hypokalemia, means that's not going to be persisting because you would have used some therapies that have shifted the potassium into the cell. So that is going to come out and potassium is going to get normalized after the dialysis, even if you have a post-HD hypokalemia. So don't worry about that. Don't treat with potassium because otherwise you will result in significant hyperkalemia. Once again, the patient has to be taken for dialysis faster. So don't do that. So these are some of the important things that you have to know with regards to the dialysis and hyperkalemia. As far as the treatment of hyperkalemia is concerned, dialysis is going to be the best treatment for hyperkalemia. That's it. So this point is the most important, crucial, that dialysate potassium should be more than 2. So don't keep it less than 2, which is associated with sudden cardiac arrest. But one problem with dialysis is the fact that dialysis will not be effective in digitalis related hyperkalemia. Even though the best treatment as of now for hyperkalemia is dialysis, but it will not work for digitalis related hyperkalemia because digitalis is a drug, or digoxin is a drug that is not dialysable. That is the reason why if hyperkalemia is a result of digitalis toxicity, do not use dialysis. Instead go for digibind. That is the best treatment as of now. Let us move on to the summary of all the treatment regimes which I have discussed till now. So what are the treatment options that are there for hyperkalemia? I can divide into 3 drugs that stabilize the cardiac membrane potential, and only one drug is available in this setting. That is IV calcium in the form of either calcium gluconate or calcium chloride. And the second drug is the group of drugs that are going to increase the intracellular shift or transcellular shift of potassium. And there are 3 drugs in this regards. One is the insulin plus dextrose solutions, and second one is the beta-2 receptor agonist like albuterol nebulization, and third one is the soda bicarbonate. These are 3 drugs that are going to work by increasing the intracellular shift of potassium, thereby alleviating hyperkalemia, transiently but. And number 3, there are some definitive potassium lowering therapies, drugs, which reduce the total body potassium itself. We have 3 drugs and 3 modalities of treatment under this heading. One is the drugs that eliminate through the GIT route. These are nothing but cation exchanges like patiromer and sodium polystyrene sulfonate that are going to use. And second, you can use renal route of elimination using diuretics, especially loop diuretics, or you can use extracorporeal route of elimination using dialysis. Clear? So these are the various treatment modalities that we have. So let us see the specialities of each and every modality. Remember, the only drug that can stabilize the cardiac membrane potential is IV calcium. Other modalities cannot have any effect on stabilizing the cardiac membrane potential apart from lowering the serum potassium. At the same time, your modalities number 2 and 3, that is agents that increase the intracellular shift and definitive potassium lowering therapies, they reduce the serum potassium, alright, but your IV calcium has no effect on serum potassium. Serum potassium will not drop as a result of giving IV calcium. And similarly, your total body potassium can be affected only with your definitive therapy like extracorporeal removal, renal removal or GIT removal regimens, but there will be no change in the total body potassium if you are using agents that cause intracellular shift. And that is the reason why agents that cause intracellular shift are only transient, the effects will be only transient, and there is a high risk of rebound hyperkalemia in this setting. Especially in patients who are having a increased total body potassium, there is a strong possibility of rebound hyperkalemia if you don't treat with the definitive potassium lowering therapy and you're treating only with the agents that are going to cause transcellular shift of potassium. So summary is over. Now let us move on to the 3 GIT cation exchanges as we have promised before. One is the SPS, that is sodium polystyrene sulfonate, otherwise referred to as kyaxylate. And second one is the patiromer. And the third one is the sodium zirconium cryosilicate, referred to as ZS9, sodium zirconium cryosilicate crystal. Mechanism of action. First of all, we have to know the site of action. SPS and patiromer acts in the colon, whereas sodium zirconium cryosilicate acts in the entire intestine, both upper as well as lower GIT. That's why it's supposed to be the most effective cation exchanger available right now. But it's not available commercially right now in India, but other 2 are very commonly used. In general, we prefer patiromer ahead of SPS because of many SPS related side effects. And mechanism wise, they bind to certain cations. Like for that matters, SPS can bind to potassium. That's what we need. And it not only binds to secreted potassium in the colon, it also binds to magnesium, calcium, and even ammonium, and even many other cations like H plus also. It can bind to a lot of cations apart from H plus. In fact, to be honest, it has more specificity for calcium compared to that of potassium, and that is the reason why many textbooks call this as non-selective drug. So SPS is a highly non-selective drug. So obviously when they bind with a particular cation, they have to release some cation. So that's what they do. They bind with these cations and they release sodium, which means SPS is a sodium containing resin or a polymer. It is sodium containing, and that's the reason for its side effect causing volume overload, because it can release sodium in exchange for this cations. And similarly, patiromer is going to bind to potassium and to a small extent with magnesium, and it can bind to ammonium also, but most importantly they bind to potassium with a more specificity compared to SPS, and they bind to magnesium also, and in turn they are going to release calcium and not sodium. The reason is they don't contain sodium at all in the first place. If at all they ask you what is the cation exchanging drug that does not have sodium, that is patiromer. This is the only drug among the three which does not contain sodium. Clear. ZS9 acts by a very selective mechanism, which means it binds to only potassium, to a small extent to ammonium, but it binds only to potassium, does not bind to calcium and does not bind to magnesium, which means it's specific only to monovalent cations. It does not bind to any bivalent cations at all, and it's going to release sodium as well, a little small amount of sodium, and once again it is sodium containing. The name itself tells sodium zirconium cryosilicate, so it is sodium containing only. So among all these three, only drug that is not sodium containing drug is your patiromer. Among all this, the most selective is your sodium zirconium cryosilicate, and the most potent is sodium zirconium cryosilicate. The most fastest is sodium zirconium cryosilicate as well. And what will be the time of onset, timeline? Time of onset is highly variable, unknown here. Typically it takes a few days to even weeks to act, so it's not very reliable, unreliable action. Patiromer on the other hand acts within 7 hours, and it normalizes the serum potassium within 1 week. Within 1 week it normalizes serum potassium. So it's very, very effective for chronic hyperkalemia therapy. Within 7 hours it starts acting, and within 1 week it completely normalizes the serum potassium if you give in the appropriate dosages. Whereas sodium zirconium cryosilicate is even more faster acting. It acts within 1 hour. It starts acting within 1 hour, and it can normalize the serum potassium within 24 hours. And the mean time for normalization is within 2.2 hours. That is the reason why sodium zirconium cryosilicate is currently being evaluated for the use of acute as well as chronic hyperkalemia. For use in both acute as well as chronic hyperkalemia, they are trying this sodium zirconium cryosilicate because it normalizes the potassium within almost 2 to 3 hours. So in general, within 24 hours, the serum potassium will normalize. It's very fast acting, and it's very, very effective and most potent also. Apart from the drug interaction wise, there are too much of drug interactions as far as SPS is concerned. Sodium polystyrene cryosilicate is concerned. It can interact with antacids. It can interact with laxatives, where interaction with these drugs increase the risk of metabolic alkalosis and bicarbonate reabsorption from these drugs, because they exchange the cations with these drugs and release free bicarbonate from this antacids and laxatives, resulting in more bicarbonate absorption, causing metabolic alkalosis. Similarly, it can interfere with digoxin, lithium and levothyroxine, where interactions with these drugs will result in reduced absorption of these drugs. The digoxin levels, lithium levels and thyroxine levels in the body can be low with the usage of sodium polystyrene sulfonate. And you have reduced interactions compared to that of SPS in case of patiromer. Not significant interactions you will be seeing, but still there is a FDA warning saying that you should not give anything 3 to 6 hours pre or post using patiromer, which means pre and post patiromer use. You should not give any other drugs at least for 3 hours. At least for 3 hours. Ideally, the guideline tells for 3 to 6 hours, but at least for 3 hours, you should not give anything before and after giving patiromer. So to avoid any sort of drug interaction. And sodium zirconium cryosilicate has no significant or clinically relevant drug interactions, which is a very, very important thing again. So it's advantageous. And side effect wise, SPS is the one that is supposed to be the most poorly tolerated among the all. Very, very poorly tolerated. And it's going to result in a lot of GIT side effects. Nausea, vomiting, constipation, diarrhea, it can cause anything. But very commonly they complain of constipation and bloating, because this SPS is one of the only agents that after swallowing, it absorbs water and swells up like anything, resulting in constipation and bloating. So it's very poorly tolerated drug. Apart from that, it can result in multiple electrolyte disturbances like hypokalemia, obviously expected, because it binds with potassium and eliminates the potassium through the GIT route. And it also binds with calcium, resulting in hypocalcemia. It also binds with magnesium, resulting in hypomagnesemia. And it can also result in sodium release causing hypernatremia and edema and volume overload state, and it can result in metabolic alkalosis as well by binding with H+, and especially this effect is augmented if you are using antacids or laxatives simultaneously, which I told you already. And there is one important serious side effect that is seen only with SPS, that is colonic necrosis and intestinal perforation. Remember, this is not seen with patiromer or sodium zirconium cryosilicate. And one other important point that you have to note is the fact that this colonic necrosis and intestinal perforation is associated with use of sorbitol use. Previously, when this drug was discovered and invented, first time when they were using this drug, they found out that this drug does not reach the colon, which is the site of action, in a appropriate quantity, and you need a laxative to push this drug towards the colon. So that's why you used sorbitol, which acts as a laxative here to push this drug to the colon, which is the site of action for this sodium polystyrene sulfonate. But later on they found that this sorbitol use is actually associated with increased risk of colonic necrosis and intestinal perforation, and that is the reason currently we don't use sorbitol along with SPS. If you want to give SPS, give without sorbitol. And we know the dose of sodium polystyrene sulfonate, it's going to be 15 to 60 grams per day if you are using orally, or if you're using enema, use 50 grams as an enema dose, but you don't use sorbitol, please. So what are the side effects of patiromer? Side effects are generally less. It can have GIT side effects, but it is much better tolerated compared to that of sodium polystyrene sulfonate. At the same time, it can also result in certain electrolyte changes, very commonly hypokalemia and hypomagnesemia. But hypocalcemia, hypernatremia and all is quite rare with patiromer because it's not sodium containing. At the same time, it's going to release calcium instead of binding with calcium, so it will not result in hypocalcemia, hypernatremia and volume overload state. In fact, metabolic alkalosis is also very, very rare with patiromer use. And there is no serious side effects with patiromer at all. And the dose we are going to give is 8.4 to 25.2 grams per day. Only orally it is available. It's not available as enema. And sodium zirconium cryosilicate, on the other hand, you can expect some GI side effects, but it's much better tolerated compared to patiromer and SPS itself. And electrolyte disturbances can happen, which can result in hypokalemia, rare. At the same time, it can result in hypernatremia and edema. Once again, it's very rare because it's sodium containing. Theoretically, it can produce hypernatremia and edema, but very, very rare in clinical practice. But it can cause hypokalemia if you are using in a extended fashion. And there is definitely no serious side effects as far as sodium zirconium cryosilicate is concerned. And the usual dose is 5 to 10 gram per day, but the FDA recommends an oral dose of 10 gram per day. So as a nutshell, SPS is associated with very, very poor tolerability, more side effects, especially dangerous side effects like colonic necrosis and intestinal perforation, but still it is very, very commonly used in low resource settings like Indian subcontinent because the cost is very less. And patiromer is emerging as a very, very good drug because of its more selectivity compared to that of SPS, lesser side effects and more tolerability, and absence of dangerous side effects like colonic necrosis and intestinal perforation. So it's preferred in advanced centers usually, but still not very commonly used in low resource settings like India because of its cost, but still clearly it's the choice right now. And ZS9 will be the future choice, and it's one of the very, very important emerging cation exchanges that will replace all these things in the future, but still not available in many centers in India. That's the idea. So let us move on to the workup of hyperkalemia. I mean, any workup starts the treatment as far as hyperkalemia is concerned because it's one of the emergency things that you have to deal with. So when you see a patient with hyperkalemia, first thing you have to see is not the workup. You have to see whether is there any features suggestive of a life-threatening hyperkalemia. That's what you have to see. If no, then you can go for definitive potassium lowering therapy in the form of cation exchange resins, or you can use diuretic agents or dialysis, extracorporeal removal. But only you can go to this regime directly only if you don't have any life-threatening features. Suppose you are having any life-threatening features, it's better to stabilize the patient first. After stabilizing, move to the definitive potassium lowering therapy. So what are the stabilizing drugs? We know IV calcium is a very, very important stabilizing drug. but that doesn't have any effect on serum potassium. But you have to give some urgent measure that reduces the serum potassium, like insulin plus dextrose plus or minus beta 2 receptor agonist like salbutamol nebulization. Soda bicarbonate will be used if the patient is having associated acidosis, especially with the pH of less than 7 point. Otherwise, it will not be effective. So now the question comes, what are the features of life-threatening hyperkalemia? What do you mean by life-threatening hyperkalemia? Number one, if hyperkalemia is associated with ECG changes. Already the membrane is unstable, that's why you're getting ECG changes. So in this setting, it's going to be really dangerous. So it's better to start stabilizing the patient as soon as possible. Second, if the patient is having neuromuscular weakness, soon they will end up with paralysis and respiratory failure. So treat it as soon as possible. Number three, if the patient is having a serum potassium of more than 6.5, regardless of the cause, it's urgent. So soon they will reach 7, and once they reach 7, it's going to be extremely high risk for developing arrhythmias and death. So you have to treat it on an urgent basis. Potassium more than 5.5 plus if the patient is having evidence of ongoing release in the form of patients having tumor lysis syndrome or rhabdomyolysis. So in this setting, it's better to treat urgently, because ongoing release means soon it will reach 7 very fast. So in this setting, it's urgent again. So it's always about the treatment that precedes workup in patients with hyperkalemia. That's why I told you this flow chart. So after this, you can work up. So in the workup, first thing you're going to review is the history, medications, renal function, and volume status. Most of the times, your etiology for hyperkalemia will be either medications or defective renal function. History itself will tell you a clear-cut idea most of the times, like hyperkalemic periodic paralysis, the time of attack, the history of previous attacks, family history. So history is really, really important. And along with that, many times your medications like spironolactone, ACE inhibitors are very, very commonly used drugs. So your medication history itself will tell you the reason for hyperkalemia, and renal function, of course, is going to tell you a very, very major data of low GFR. Low GFR means straight away you don't need to do any other workup at all. So low GFR hyperkalemia means it's a kidney disease related hyperkalemia. So there's no point in evaluating that hyperkalemia as well. So based on this, you can split into medication related hyperkalemia. If the patient is taking ACE inhibitors along with spironolactone, why you want to evaluate further? I don't think there is any need to evaluate further. So just that is the cause of hyperkalemia. Gone. Or it could be low GFR related. If the creatinine is high, GFR is low, there's nothing else you have to do about it. So it's a kidney disease, and there's no need to evaluate hyperkalemia further. Or it could be pseudo hyperkalemia. Sometimes it can be very evident from the history and evaluation itself. Or it could be hypovolemia related. When you see patients who are having hypovolemic state or low effective arterial blood volume, and those patients having hyperkalemia is quite expected. So need not evaluate further. So if you don't have any clue with regards to medications, your kidney function or volume status, then you are going to go for the actual workup. So which means if no etiology is found after your basic evaluation, then you go for the actual workup, where I am going to look at the TTKG, urine potassium. Urine potassium means I'll be seeing spot urine potassium as well as 24-hour urine potassium, and I'll be using a potassium creatinine ratio. Potassium creatinine ratio, otherwise referred to as a KCR. I'll be seeing this in the urine potassium creatinine ratio. These are 3 investigations I'm going to rely upon. The most important question to answer here is why you're going to use TTKG and why not your fractional excretion of potassium, because there is fractional excretion of sodium which is commonly used, fractional excretion of urea which is commonly used, fractional excretion of uric acid which is commonly used, fractional excretion of even calcium which is commonly used, but we don't commonly use the term fractional excretion of potassium. Instead, only for potassium we are using this transtubular potassium gradient. Why is that so? First, for that you have to know what do you mean by fractional excretion of a substance. It is defined as amount of substance that is excreted or cleared divided by amount of substance that is filtered, which is equivalent to the glomerular filtration rate. So amount of substance that is excreted will be equivalent to the urinary clearance of a substance. Clearance of any substance is given by the formula UV by P, where here I'm talking about a substance X. So urinary concentration of a substance X divided by plasma concentration of a substance X multiplied by flow of the urine defined as V. And the GFR is nothing but creatinine clearance. Creatinine clearance vaguely correlates with the GFR. So I can write again creatinine clearance as urinary creatinine divided by serum creatinine multiplied by flow of the urine. Here you can see by simple mathematical principle my V will get eliminated. So which will result in a formula like this, Ux by Px multiplied by plasma creatinine by urinary creatinine. That's it. So this is the formula for fractional excretion of any substance. So if you want to know the fractional excretion of potassium, that will be translated as urinary potassium divided by serum potassium or plasma potassium multiplied by serum creatinine or plasma creatinine divided by urinary creatinine. So this is going to be the fractional excretion of potassium. If you want in percentage, multiply by 100. That's it. But why this is not followed for hyperkalemia perspective, even though it can give you an idea, it's not like you cannot use it at all, but it's not generally preferred. Why? Because potassium is actually affected by one other important entity apart from this excretion and reabsorption, that is solvent drag. For that matters, you can understand in the proximal part of the nephron itself, in the PCT, potassium is actually absorbed along with water by a principle called solvent drag, which I have discussed in detail in the last chapter itself. But please understand the fact that the distal nephron also contributes to the significant amount of solvent drag through ADH action. Here ADH mediated water reabsorption is very, very important, vitally important, and that is also going to take a lot of potassium through solvent drag. And remember, the water that is moving here is going to be completely dependent on the medullary interstitial hyperosmolarity, which also we have discussed already in detail in many previous sections. So what I am trying to tell is the fact that urine osmolality indirectly tells you the amount of water that is getting reabsorbed and indirectly tells you amount of potassium that is getting reabsorbed as well as a result of solvent drag. So you have to use a formula that accounts for this solvent drag and resultant potassium in the urine. So urine osmolality is a good indicator for amount of water that is absorbed, and you can use the same for measuring the amount of potassium that is going to get excreted as a result of solvent drag as well. So what I'm going to do is I'm going to use a new formula called transtubular potassium gradient, where I'll be using urine potassium by serum potassium, which will be adjusted to osmolarity rather than my creatinine. So which will be translated as urine potassium by serum potassium multiplied by serum osmolality by urine osmolality. Clear? So this is the formula for transtubular potassium gradient. So whether transtubular potassium gradient is accurate or not, answer is unknown even now. Many researchers still are going on about the urea cycle. Urea cycle also affects the urine osmolality to a great extent. That's what the current research tell. And if that is going to affect the urine osmolality, then TTKG becomes a waste. So the results are awaited, and we really don't know whether how much is the urea handling by the kidney and urea cycle that is going to affect the urine osmolality. As of now, you are using TTKG, but the results are awaited as far as the urea handling is concerned. But you have certain rules where you can use TTKG, otherwise you cannot use. First rule is the one that your urine osmolality should be more than the serum osmolality to use TTKG. Point number one, very important. And second, your urine sodium must be at least more than 20 milliequivalents per liter to tell that there is adequate distal sodium delivery so that potassium secretion can happen. So if you do not have these two, any of these two, you cannot use TTKG as a reliable indicator. So you have to have this to use TTKG as a reliable indicator in patients who are having hyperkalemia or hypokalemia. So based on this, I can push them into two entities. So patients who are having increased cell release of potassium or reduced cell uptake of potassium, both are the same, either increased cell release or reduced cell uptake of potassium, which can be defined as TTKG of more than 11. So TTKG of more than 11 tells you the renal function is normal, which means it's appropriate for hyperkalemia. In hyperkalemia, kidneys have to excrete more potassium outside, and that's what they're doing. TTKG more than 11. And urinary potassium more than 40 milliequivalents per day. Remember, spot urinary potassiums are highly biased and not so good to use. So instead, we are going to use a 24-hour urinary potassium. But even though it's cumbersome, that's the preferred one, more than 40 milliequivalents per day. But that's not so like fast as well, especially in urgent settings. Or alternatively, you can use a little less reliable but a good indicator called potassium creatinine ratio. If it is more than 200 milliequivalents per gram, that also tells that the patient is having increased cell release related hyperkalemia and the kidneys are okay, not a problem. So next, group of disorders are ones that have reduced renal excretion of potassium. In this setting, your TTKG will be highly inappropriate for the hyperkalemia, which means it will be less than 7, which means kidneys are not excreting enough potassium for the level of potassium that you're seeing in the blood. That's what it means by TTKG less than 7. Or if the urine potassium is less than 30 milliequivalents per day, the 24-hour urine potassium less than 30 milliequivalents per day, spot potassium are not used. Or if the potassium creatinine ratio is less than 20 milliequivalents per gram. In all this setting, it is defective renal clearance of potassium, and that's why you are having a hyperkalemia. So whenever you are confirming that it's a reduced renal excretion, we have to give a fludrocortisone test. Remember, you have already ruled out a low GFR cause. We are not going to think about a renal failure here. I told you low GFR related hyperkalemia means I'm not going to evaluate any further. So reduced renal excretion and I don't have etiology, then I have to give a fludrocortisone test because I have to rule out aldosterone deficiency versus aldosterone resistance. So if fludrocortisone, after giving fludrocortisone, if my TTKG becomes more than 7, it improves, means it's aldosterone deficiency, clearly. And you have a whole lot of cause of aldosterone deficiency like low renin related aldosterone deficiency and high renin related aldosterone deficiency like adrenal insufficiency, ACE inhibitors, heparin use. So much causes are there. And low renin means diabetic kidney disease, NSAIDs, beta blockers, many conditions. And even after giving fludrocortisone, your TTKG is less than 7. Some books tell less than 6. If it's less than 7, which means it's aldosterone resistance, which means fludrocortisone is a mineralocorticoid. So even after giving a mineralocorticoid, there is not much potassium excretion that is happening, means there is a tubular resistance to aldosterone. So you have a lot of conditions with respect to aldosterone resistance which you have seen, right from the problems at the mineralocorticoid receptor level, it could be problems at the epithelial sodium channel level, or it could be pseudo hypoaldosteronism type 1 and type 2, autosomal dominant type, autosomal recessive type, Gordon syndrome, or you might be having a transient pseudo hypoaldosteronism in the form of obstructive uropathy, or it can result in patients who are having upper urinary tract infection like pyelonephritis, or finally it can happen due to unknown reasons in patients with SLE, sickle cell disease, or amyloidosis. So you have discussed in detail already. Clear? So this is how we are going to evaluate a patient with hyperkalemia. Please understand the fact that if the patient is already having a high creatinine and an obvious cause for hyperkalemia like medications, no need to evaluate any further. It's very, very clear about the etiology now. So no need to evaluate any further. Clear? So after finishing off the workup of hyperkalemia, let me discuss some of the cases with you. Whenever you see the ECG, it's always important to analyze the history properly. The ECG is something, is not like you just see it and interpret. You always go back to the history, clinical features, and analyze all these things and then interpret the ECG, which is going to be very useful and easy. So here the history clearly tells the patient is a known case of aortic stenosis. And this patient is likely to have a left ventricular hypertrophy, and he's complaining of exercise intolerance and chest pain during exercise, and that is expected because of the significant left ventricular hypertrophy and low coronary blood flow, resulting in demand-supply mismatch causing all these problems. And there will be significant LVH in patients with aortic stenosis. And this ECG has been diagnosed as hyperkalemia by one of my residents. But why it is not a hyperkalemia? Let us see. This ECG satisfy the criteria for tall T waves? Absolutely yes, because you are seeing almost T waves of magnitude reaching 4 large boxes. T wave magnitude in this ECG is almost 4 large boxes, which means it's 20 millimeter magnitude T wave in the precordial lead, which is clearly suggestive of a tall T wave without a question. In many of the precordial leads, you are having tall T waves. But whether these tall T waves are related to hyperkalemia or not, answer is absolutely no. Why? Because these T waves are asymmetric. You can see there is a slow upstroke and a rapid downstroke, as I told you before. And if you see the symmetricity, it is definitely not symmetric. Clear? It's definitely not symmetric, and it is asymmetric T wave. As I told you, asymmetric T waves, even if they are tall, is not suggestive of a hyperkalemic T wave. So this is not a hyperkalemia. Here the T waves are tall just because of the left ventricular hypertrophy itself. And this patient is having a left ventricular hypertrophy. Yes, in general there are multiple criteria for telling left ventricular hypertrophy, but in general we use a criteria called Sokolov-Lyon criteria, which is more specific but less sensitive though, but we'll be discussing that in detail in the cardiology section. So you're going to use the S wave in V1 and you're going to add up with R wave in either V5 or V6, any one. And the addition, if it is more than 35 millimeter, you can call it as left ventricular hypertrophy. So let us do that. Let us see whether you are seeing LVH or not. So yes, definitely. So start S from here. So it ends up here at this point. So almost 5, 15 plus approximately 2. So the height of the S wave here is almost 17 millimeter. So S in V1, then R in V5 or V6, you can go anywhere. So let us see the V5 here. So V5 starts here. So 5 millimeter, 5 millimeter, 5 millimeter, 5 millimeter, 5 millimeter, and another 4 millimeter and another 1 millimeter here. So 25, 29, 30 millimeter almost is the height of the R wave in V5. So SV1 17 millimeter plus RV5 almost 30 millimeter, which comes up to approximately 37 millimeter, which definitely satisfies the voltage criteria for left ventricular hypertrophy, and Sokolov-Lyon criteria is satisfied, and this patient is having LVH, and this patient is having a tall T wave which is asymmetric, not due to hyperkalemia, which means this tall T wave must be due to left ventricular hypertrophy and not due to hyperkalemia. Interestingly, this patient's serum potassium was only 3.9 milliequivalents per liter. This is not hyperkalemia. And clearly the history is also suggesting of LVH because of aortic stenosis, and the patient is appropriately presenting with excess intolerance and excess induced chest pain in this setting. Next case study. History clearly tells patient is a diabetic patient on AC inhibitor and a known diabetic kidney disease. Diabetic kidney disease itself can cause hyperkalemia. AC inhibitors itself can cause hyperkalemia, and diabetes insulin deficiency itself can cause hyperkalemia. So there are multiple situations in this patient which can predispose to hyperkalemia. So let us see in that perspective. So this patient came with fatigue. That's the only complaint. And we checked the serum potassium. It is 5.9 milliequivalents per liter. And yes, this is the patient with hyperkalemia. And you are seeing a tall T wave. Definitely, there is no doubt about that. So you are seeing 1, 2, 3, 4 large boxes. So obviously anything more than 2 large boxes, more than 10 millimeters is tall T wave. So there is no doubt you are seeing a tall T wave. But my question is whether this tall T wave is associated with hyperkalemia or not. So you can see a smooth upstroke and a smooth downstroke, and this T wave is very, very symmetric. If I put a line in the center, it's absolutely symmetric tall T wave, which is confirming that this patient is having definite hyperkalemia. So this is a hyperkalemic T wave, and this is how it's going to look like. And apart from that, you don't have much of hyperkalemic change, just a tall T wave, which is quite expected at this potassium. So that's fine. Let us move on to the next case. Here it's very clear that this patient is suffering from type 1 diabetes on insulin therapy and recently started on AC inhibitors, and the patient is having a DKD. Why they should have started AC inhibitor? Because the proteinuria and diabetic kidneys. To reduce the proteinuria, they have started with AC inhibitors. And patient is a known case of type 1 diabetes. There are multiple kind of things that predispose to hyperkalemia in this patient. Diabetic kidney disease itself predisposed to hyperkalemia, and type 1 diabetes insulin deficiency itself predisposed to hyperkalemia, and starting AC inhibitors definitely predisposed to hyperkalemia as well. With that perspective, let us see whether this patient is having hyperkalemia or not. First, see the T wave. The T wave is not actually really tall here. So you are seeing probably one large box, 1, 2, 3, 4, 5 and 6, 7. So which means the T wave height is only hardly 7 millimeter, which is actually not fitting into the tall T wave criteria at all. But still this patient is hyperkalemic. Actually, if you take this patient's potassium was a humongous 6.9 milliequivalents per liter. So this was this patient's potassium at presentation, and this is huge. And you don't get a tall T wave at all. Possible. But see the character of the T wave. It has a very smooth rise and smooth fall, which means it's very symmetric. And if I draw a central line here, and I can see this T waves is once again absolutely symmetric, and this is suggestive of a hyperkalemic T wave for sure. So even though if this patient is not having a tall T wave from our perspective, still this is definitely a hyperkalemic T wave. So it clearly tells you. And at the same time, you can see a significant widening of the QRS here. So QRS width is significantly widened. And I told you anything more than 240 milliseconds, if QRS is widened, it is equal to hyperkalemia. That's it, nothing else. No other condition in the world can widen the QRS to more than 0.24 seconds or 240 milliseconds. So this is a very, very wide QRS. At the same time, we are not seeing any P wave. I don't think you see any P wave. So this is the QRS here, and almost the patient is going for a sine wave pattern. Significant QRS widening, more than 0.24 seconds, definitely hyperkalemia. And at the same time, I'm not seeing any P waves at all. Where are the P waves? So which means this might indicate a sinoventricular conduction or a junctional rhythm also. So absent P, symmetric T waves, even though it's not tall, and significantly widened QRS almost going into sine wave pattern, tells you that this patient is having a hyperkalemic ECG for sure. And after therapy, so here they have clearly mentioned that they have treated this patient with insulin and dextrose along with IV calcium. Once they have treated this patient with insulin, dextrose and IV calcium, the conduction has significantly improved. And you can see now the QRS width is much better. Still, this patient is not having a P wave, which might improve subsequently later on, but it might indicate either a sinoventricular conduction or it could be a junctional rhythm also, which we have no idea, because in hyperkalemia it's very difficult to predict from a standard 12 lead ECG. So, but one thing for sure is the conduction has significantly improved in this setting. The QRS has narrowed significantly after treatment, which is a sign of improvement after therapy. But this could be a junctional rhythm or it could be a sinoventricular conduction also, because P wave is not there. In hyperkalemia, I am not able to comment on that. Let us move on to the next case. This is a patient who is posted for TKR, total knee replacement, and this is his baseline ECG. This is the baseline ECG of the patient. Baseline ECG of the patient clearly shows many things. Initially itself he is having a RSR pattern. When you have an RSR pattern like this, that indicates a right bundle branch block. Apart from that, probably you can see an RS pattern here, 2, 3 and AVF, along with that QR pattern in 1 and AVL. This is telling you that this patient is suffering from a probable left anterofascicular block as well. But details of all these things we'll be discussing in the cardiology section. Don't worry about that. But I'm telling you, this patient is having a baseline prolonged QRS, widened QRS with a right bundle branch block and a left anterofascicular block, and he's having a sinus rhythm. You can see a P wave everywhere. So P wave is very clearly seen, and it's definitely a sinus rhythm. You can see the P wave over here. So definitely this is a sinus rhythm. So final diagnosis of this is sinus rhythm, right bundle branch block, left anterofascicular block, wide QRS due to all these blocks, but that's fine. And during anesthesia induction, they've administered succinylcholine. As soon as they administered succinylcholine, the ECG became like this. So whether this is hyperkalemia or not, yes, this is hyperkalemia once again. That is due to scoline injection. Scoline injection can cause hyperkalemia, as I told you before, due to increased muscle contractions and potassium release from the muscle. So how come this hyperkalemia? Already patient is having a wide QRS in the past. So as you see, from an overview, this is the QRS here and this is the QRS here. Definitely there is more prolonged QRS after giving succinylcholine. That is suggestive of probably hyperkalemia induced widening of QRS. At the same time, see the T waves. That's what is going to give you the idea. So let me tell you the T waves here. Initially, before treatment with succinylcholine, the baseline ECG showed there is a slow stroke initially, then followed by a rapid stroke, which means when you see the symmetricity, it is very clear that the T waves are asymmetric. No doubt about that. See the T waves in the next ECG, how symmetric it is. Same T wave, now it has become really smooth And if you see the symmetricity of the T wave, you can see it is absolutely symmetric now. So increased QRS widening compared to the previous ECG, and T waves initially was asymmetric, now become more symmetric, is absolutely suggestive of hyperkalemia in this patient induced by succinyl choline. And this patient's serum potassium that was measured immediately after giving succinyl choline was approximately 6.2 milliequivalents per liter. That clearly explains that this hyperkalemia is due to succinyl choline. Let us move on to the final case where the patient is a non-ischemic dilated cardiomyopathy, was on furosemide, which is actually a hypokalemic agent, not hyperkalemic agent, but he is taking multiple drugs that can produce hyperkalemia like ACE inhibitors and spironolactone, which can produce resistance at the mineralocorticoid receptor level and which can reduce the aldosterone synthesis itself. And this patient is coming with fatigue to your emergency, where you find the patient is having a BP of less than 70-40 millimeters of mercury, but still has a pulse. So it's not a cardiac arrest, but still is having a very low BP, and the patient is actually in shock. When you see the ECG, it is actually suggestive of a ventricular tachycardia. We are going to discuss in detail about this in the cardiology section, but right now let us see what are the key features. This is a monomorphic VT. It is likely regular. I'm not telling surely regular, but it is likely regular at this rate. And this patient is having a rate of definitely more than 100 to 120 per minute, which is definitely a criteria for diagnosing ventricular tachycardia. And it's a premature ventricular complex for sure, which is happening at a rate of more than 100 to 120 per minute and is regular in rhythm. And the patient is probably having a AV dissociation, which is not found in this ECG because at this rate I'm not able to find out. And definitely this patient is having a wide QRS or a broad complex QRS, and these are the diagnostic criteria for a monomorphic ventricular tachycardia. Clear? And here the QRS is so wide that is almost showing a sine wave pattern. And since it's a sine wave pattern, if you take the QRS width here, it will be definitely more than 240 milliseconds, 0.24 seconds. As I told you, wide QRS that is having QRS width of more than 240 milliseconds is definitely a hyperkalemia. Whether or not VT is there or not doesn't matter. So this VT, I will surely take it as a hyperkalemic VT for sure, without a doubt, because it's so prolonged. No other condition can produce this much of prolonged QRS complex apart from hyperkalemia. And we have also cross-checked with the serum potassium in this guy, which was approximately 7.4 milliequivalents per liter, which is humongous. And that's the reason why this patient is having this particular complication of ventricular tachycardia. So this correlates actually because the ECG is also suggestive of hyperkalemic VT, and patient is taking multiple drugs that is suggestive of causing hyperkalemia. So there is no doubt about that. And this patient was treated with IV calcium, salbutamol nebulization, and insulin plus dextrose, and after some time the ECG was repeated, which shows a dramatic improvement in terms of QRS width, which now almost shows a normal QRS or a narrow QRS because the membrane has been stabilized now, and at the same time the potassium also has been lowered to some extent. So that is the reason why you can see such a dramatic change in the follow-up ECG. But still this patient is having a complete heart block. Again, I'm not going to discuss the details of complete heart block in this ECG, but you can see AV dissociation, multiple dissociated P waves at different places. So this is definitely AV dissociation without a doubt. You are seeing multiple dissociated P waves at different areas. So it's AV dissociation, and hence I'm diagnosing complete heart block, which means complete heart block has not yet resolved. Complete heart block itself may be due to hyperkalemia, or the patient may have underlying complete heart block and then he could have developed a hyperkalemia. Both are possible. But anyway, I need further evaluation. I have to check up with the previous ECGs because the patient is a known case of DCMP, which means surely you would have taken a previous ECG. So I have to follow up with the previous ECG, which was taken at baseline before starting the drugs. And if it shows a complete heart block, then I'll take it as a baseline complete heart block. Or if it's not showing any complete heart block, I'll wait for some more time because this hyperkalemia related complete heart block will resolve over a period of time. So this is definitely hyperkalemic ECG for sure. And after treatment, it shows a dramatic to dramatic improvement. Fine. All right. So we have completed the hyperkalemia with a great depth and a great detail. And all these things, whatever I told you, are really, really important as far as a clinical practice is concerned. And many, many questions are going to be there in the exams. And especially the management of hyperkalemia is going to be the most important aspect of your questions. So just go through the video once again and take a proper notes, and that must be more than enough for your exams. And we'll see in the next video on hypokalemia.